So, welcome everyone. Welcome to this webinar on techniques surrounding ultrasound guided injections. I'm Andy Thomas and I'm Director at PhysicoIP, and we distribute the Alpinion MSK diagnostic ultrasound system. So, following on from our last webinar, which is on the education pathway, this session is going to be more focused on techniques and top tips. So we've got around 500 people registered again, so that's really great. So thanks all for giving up your time and joining us. And as I said before, as we've got so many, if you could turn your cameras off, that would be very helpful. And also if you could put your microphone on mute to avoid any background noise. So the format's going to be slightly different in that each of our panel are going to give a presentation, and then we'll have a 5-minute Q&A on each section. So if you do want to ask a question, then put it in the comment section on the right-hand side, and we will address that within the time that we've got. So our guests, you'll all recognise him by now, Chris Myers, who is Clinical Director at Complete Physio and Co-Faculty Lead for the Sports Medicine Ultrasound Group. Chris has been carrying out ultrasound guided injections for over 10 years and performs over 500 guided injections a year. Welcome again, Chris, and thank you.
Thanks, Andy.
Mike Bryan making his debut with us tonight. So he is an NHS appointed consultant MSK physio and sonographer, and he's been using ultrasound since 2007 and has a particular interest in tendinopathy and ultrasound guided interventional treatments such as shoulder barbotage, hydrodistension, and guided injections. Thank you, Mike, and welcome.
Thank you.
Then we're also joined again, which I'm pleased to say, by Dr. Lorenzo Maschi, who is a specialist sports and musculoskeletal doctor who has worked for various elite sporting institutions. He's also developed an online ultrasound guided injection course and is a recognized worldwide expert in ultrasound guided interventions. Welcome.
Thank you.
Thank you, Lorenzo. So before we go over to Chris for the first presentation, it'd be helpful again if we could find out what professions you are and where you're based, again, just to give some context to when the panel are discussing things. So if you could complete that, please. I had to add a few and change a few on this one. Interesting, more from around the world this time. Okay, great. We'll end that there. So there you go, guys, just for your reference. So it would be helpful, actually, while we're doing this, if you could put down, because there's quite a few in other there, 25%, if you could just let me know what your profession is, that will help us for future ones in the comment section.
You've missed out sonographer. That's probably a big part.
Yes, good point. Right, okay. Okay, right. So, Chris, I will hand over to you, please.
Great.
And yeah, we'll get going.
Right, let's share this. So thanks for putting this on again, Andy. We thought we've done a few of these, and we've done, we've looked at competency and we've looked at different elements, but we often get feedback about, right, how do you guys actually do that injection? Like, what are the top tips for that injection? So we've just picked a selection. We'll start off with a basic one, which is the subacromial bursa. And then between us, we're just going to go through a few ones where we think where we all do quite a lot of them, where we feel we've got some knowledge to share. So I'm going to kick us off with the subacromial bursa and the hydrodilatation. In terms of when we teach the course, so myself, Mike and Lorenzo teach on the 2-day SMUG cadaveric course. And we just talk a lot about injections, about what position do you use, when do you inject it, all those sort of really clinically relevant questions. And there's an awful lot you have to consider when you're planning an injection. And we're just going to focus on a few things. The analogy I always use is, let's play darts. So when we're trying to hit a bullseye, which is basically what we're going to do when we're trying to hit a joint or a soft tissue target, it's really important that you line everything up. You don't want to be leaning over, looking over the shoulder, looking at the machine over there. It's really important that when you set up your injection, you're probably spending around 70 to 80% of the time, if not more, just planning where everything's going to be. The actual injection side of it takes very little time, particularly if you set it up properly in the first place. So it's really worth trying to think about that with all of the injections that we do. So if we look at the injection on the right, so this is Lorenzo injecting or pretending to inject my shoulder, you can see that we've got the machine, sorry, we've got Lorenzo, and then there's me, and then there's a machine. And Lorenzo's body posture is towards the machine, and the needle, just like the dart, is pointing towards the machine. And that, at the end of the day, it's all about trying to get that needle on the ultrasound image. So it's really important that you try and line things up. It's very easy to get this wrong. Now, we're going to talk about the bursa. I used to always do my bursa injections in sitting until a patient fainted. And I had a very busy clinic, and it took an awful lot of time to catch up. And also from teaching an awful lot and teaching new people to do guided injections, I have found that using a supine position is much better for the clinician and also better for the patient. So the advantages of this position are pretty obvious. The patient is relaxed. If you're new to doing guided injections, you don't want the patient staring at the needle. You don't want the patient staring at the image. Okay, it just takes the pressure off the patient. From a clinician point of view, it's really nice. I'm always sitting down, and what it does is it allows me to get right behind the probe. And it's really important when you're trying to get the needle in the image that you're looking right at the side of the probe to ensure that you get the needle in the middle. In terms of the position I use, I get them into slight extension, which brings the bursa, the nice big part of the shoulder and the cuff, to the front of the shoulder, as you can see in the image. And I generally get them just to hold onto their belt so the elbow drops back, or you can just get them to hold like this and just drop the elbow back into extension. Okay, and that gives you a really nice image. The other big tip that I can give you is once you've found your target, the whole thing is going to go wrong if the probe moves even 1 millimeter. Because as soon as you move your probe, you're going to lose your target. So even if you've got the needle on your image, if you've moved that hand, then you're going to lose your target tissue. So as you can see here, having a really good base of support for your hand, so my hand there is pushing onto the shoulder, then my hand is very stable, particularly with shoulders, because obviously it's a round object. So it's really important to get the stability of the probe. It's not all about the hand that's actually doing the injection. So when I carry out a bursa injection, I generally will choose this rainbow view. So this is a transverse image. This is the humerus, this is supraspinatus, this is the deltoid, and this potential space here is going to be where your subacromial subdeltoid bursa is. There's absolutely no reason, and it is just as easy to do a longitudinal view or a parrot beak view. And this image here, you can see these two bright white lines are your peribursal fat layers, and in the middle there is your bursal target. Okay, so actually carrying out the injection, there's a few key things to look for to make sure that you're in the target tissue. Okay, the first thing is that when the injectate goes in, you can see that the fluid flows away from the needle tip. You don't want it accumulating around the needle tip itself. And this is quite clear that that potential space, which is the bursa, is distending nicely. When you inject into that soft tissue plane, there shouldn't be too much pressure in your syringe. It should be quite low, but it isn't going to be as low as when you go into a joint necessarily. If you look at the image on the left, this is why it's so important to make sure that you're right behind the probe to ensure that you get in the middle of the needle. And not just that, you need to imagine that when you go into the middle of the probe, that it's actually going through all the way in the middle of the probe. You don't want it going off into an oblique angle, because you want to make sure that you see the needle tip. carrying out this bursal injection, if you've got reasonable ultrasound skills, it should only take a couple of hours to be able to carry this out, because the way we teach is it does take it down into quite a closed skill. So as long as you've got some probe skills, this makes things quite simple. And obviously you can also do it in longitudinal, and you can see here the needle going in and again going into the bursa. A little tip that I can give you is, if you're not sure whether you're in the correct soft tissue plane, go from an in-plane approach to an out-of-plane approach. So if you look down at the bottom right here, there's the needle tip, which is just outside the bursal plane. So it's quite useful to be able to transfer from longitudinal and transverse and have a look at the needle tip. But using the out-of-plane, even if you've gone in longitudinally, you can then change into an out-of-plane approach to have a look to see whether the needle tip is in the correct tissue plane. So if we go on to hydrodilatation, which I'd say is a little bit more of a skilled technique, I think the subacromial bursa is probably in our top 5 that we would teach somebody at the more basic level when you're first getting started. And a hydrodilatation, which essentially is just an intra-articular glenohumeral joint injection, is probably a slightly more advanced skill. So traditionally, although interestingly enough, the hydrodilatation has been around now for about 30 years, I found out. But normally we would just do a steroid injection for, or certainly traditionally I would do a steroid injection for an adhesive capsulitis. However, it's not that new, but another technique that you can use is a hydrodilatation that most of you will know, is basically where you put the steroid in like a normal injection, but you also pump in quite a lot of saline. And the amount of saline you put in will vary depending to your local policy and guidelines. And in the research varies from 10 to 100 mils. So it's very difficult from the research to say what the optimal amount is. Now, the whole premise of the hydrodilatation is obviously to reduce pain because you've got your steroid in there. But we know that the volume of the joint capsule for a glenohumeral joint, when you get a frozen shoulder, gets a lot smaller in frozen shoulder. So this obviously at face value tries to stretch the joint capsule so it doesn't just reduce pain, it also increases your range of movement. Those are the advantages of a hydrodilatation. We think that maybe it gives you more pain relief, but it does give us the potential to maybe improve the range of movement in those phases of frozen shoulder. And maybe, you know, certainly we get quite a few patients that see this as a bit of a cool advanced technique, and maybe there is an increased placebo effect there as well. However, we think those are advantages, but we'll go on to what the research says in a minute. But there are definite disadvantages. It does take longer. It takes more of a setup. It's more complex to learn. It's more complex for the clinician. Potentially, it has more pain afterwards. And potentially, it does have slightly increased side effects. We can talk about that a bit later. So initially, and certainly when I was first shown this injection technique, I was told I needed to get the pop. And I think the premise was that by building up the pressure, you eventually got a pop, and essentially you were releasing or tearing, or you were doing something to the capsule. Now, there's been quite a lot of evidence that has looked at this with some very cool research. And essentially, it is the most likely explanation of the pop is just that the capsule will give at its weakest point, which is around the subscapular bursa and the biceps sheath. So it's not giving at the bit where frozen shoulder, or we believe frozen shoulder, is really affected around that coracohumeral ligament and superior ligament. They've also done research to look at whether or not you do need to use high volume or low volume. And again, the research doesn't support either way. However, there is a trend in the research that it is not necessary to it's not necessary to get the pop. And actually, if you get that release in pressure, then that may actually reduce the pressure overall and therefore reduce the ability to get some stretch from the inside. And potentially the premise that we're trying to do here is that we're trying to encourage some creep within the capsule. So therefore we need the fluid inside the capsule to get that. And actually, if it does give and pop, you are then allowing the fluid to escape potentially into the subscapular bursa and the long head of the biceps sheath. So overall, and the research doesn't show that the more you put in, the better it is, and it doesn't show the less you put in. So I think most of us, or certainly from the guys that I talk to, and more than welcome to get opinions on this after, or I can tell you what I do, is I generally will do around 35 mils. But it varies massively between the size of your patient, the stage of the adhesive capsulitis, and obviously how a really restricted capsule, you won't potentially get that into the joint. So I have a big 30 mil syringe with saline and depomedrone in, just 1 mil of depo. I have a 5 mil syringe of local anesthetic. I use long greens. Now, you can also use a 3-way tap, and you can use tubing as well. They both have advantages. It's not the way I was trained, and I feel like I do a reasonable job with the ones that I do. So the way I do it is I will inject the 5 mil syringe of local anesthetic, talk to my patient, wait a little bit, and then I will change the syringe. Obviously, you lose a bit of pressure at that point, and then I'll put the 30 mil of saline and depomedrone in. If you get to 30 mils and you can get a lot more in, then if you don't have the 3-way tap, the only option you've got is to take it off, try and keep some pressure and add it on. But generally, I've just been quite happy with the 35 mils, particularly as the research doesn't say necessarily that you need to go with high volume. From a technical point of view, side lying is, in my opinion, definitely the best way of doing it. Obviously, if you're used to doing it in sitting, then you don't need to necessarily change. But side lying has made this much easier for me. I generally don't have the arm across like this because I think that can, particularly if they're tight at the back, that can cause a little bit of pain. So I just have the arm down by the side. I have the machine at the back, so you can see I've got that sort of darts principle going on. The biggest mistake you'll make is exactly what the probe and the needle is doing at the moment, which is you think that is going to be deep enough. But I can guarantee, and I'm sure most of us have done it, is if you go in at that angle, so you can see the needle is not vertical, okay, it's more in line with the probe, you're going to end up very shallow. If you end up shallow, you have to go all the way out pretty much and start again. So the best tip I can give you, and this has made things, it takes away a lot of the thinking actually, you just have to do this, is you have to make sure that the needle is vertical, just like you're trying to pierce the bed underneath, okay? And if you stick to a vertical needle, you will generally go nicely into the joint. And obviously what we're trying to do is target this area here, just underneath the capsule. You can go a little bit further down if you want. And certainly when you go through the capsule, you will get that feeling of that release as it gets through. So this is an injection of a hydrodilatation. This is one of Mike's. He uses a 3-way tap, so we can always discuss that with him. So you can see the needle in there, and it's really important that when you're in the right area, and you can see it on the syringe, the pressure will go a lot lower. You shouldn't have to force anything in, and you can see the superior capsule lifting up and the injectate moving away, and obviously you can see the anechoic area. It's not accumulating around the needle tip, and you can see with Mike's plunger, it goes down quite easily. So that's a hydrodilatation. So you know you're in the joint because the injectable flows away, the capsule lifts up, and then a couple of tips that I always do, you're essentially doing an arthrogram. So after I've done a hydrodilatation, I will always do 2 things. I will check the long head of biceps because that should have fluid in it if you've gone into the joint. And also I will do a quick scan of the rotator cuff because obviously if there is a cuff tear, a full thickness cuff tear, then the fluid will leak out into the subacromial bursa. So that's a nice little tip for seeing whether or not there is a significant rotator cuff tear. When you look at the evidence, and it's interesting, when you talk to people, or when I've talked to people, there seems to be this thing that hydrodilatation is much better than steroid. And I think that's quite anecdotal. And my personal experience is that it does vary whether you do steroid or whether you do a hydrodilatation. It's very hard to predict who's going to do really well and who's not going to do very well. So overall, the research does lack high quality studies, no surprise there. There's a massive variation in the volume that's injected, and overall in the high quality placebo-controlled prospective trials, there is no difference between corticosteroid alone and hydrodilatation. And again, there is no overall consensus exactly how we should be carrying this out. My personal preference is, if, for me, with a frozen shoulder that's clinically very frozen and they're waking up at night, etc., and it's not getting better, I think the key thing in that first phase is to get the steroid in as soon as possible. And after that, it may be, as you know, if it's 3-4 months down the line and their pain is they get pain, but it's also stiff, then you may consider the hydrodilatation. And I do sometimes have patients where I do a steroid at the beginning, and then 4 to 6 weeks later, as it becomes less painful and it becomes more stiff, then I may consider the hydrodilatation at that stage. Okay. That's my first bit. Not bad timing, because I do like to talk, but
you did. I was conscious, but you didn't.
Yeah, I was conscious too.
So we've got some questions coming through here, Chris. So I'll start with Dan. And is a green needle always long enough to get into the joint, especially with bigger patients, e.g. rugby players?
Yeah, really good question. So the first thing, Dan, hi Dan, the first thing is, if you go vertical, you're not wasting that much needle, okay? But to answer the question, absolutely not. Mike got me into this. We call these the big mics. Do we call it the big mics or something like that?
Mike's
so it's
big
120. Green. What do you call it, Mike?
Mike's big green.
Mike big screen. That's what he calls it. So you can get 100 or you can get 120 millimeter greens. So I always have them in clinic. I used to use spinal needles. I don't love them. So I get the long greens, and for your rugby players, you must buy some long greens. So they're 120 mil greens. They're not like the spinal needles, so there's none of that faffing, and they're really easy to use. And that's what I use for hips.
Okay, great. Then a question from Harriet: does everyone also use CSI in hydrodilation? Can you do without?
So there are studies that have done it without. Okay, and they have shown some effect, some positive effect. And the other interesting thing from the studies, so the answer to the question is yes, but the interesting thing from the studies is that there is evidence, or at least there is a trend, that actually the hydrodilatation may not do anything, and actually it's just the fact that you're putting steroid in. And that I think is valid. My personal opinion is, in stage 1 of frozen shoulder, unless they've got contraindications or something like that you're concerned about, I would suggest that it does need to be done with steroid. I would also, just as another point on that, I would never inject a shoulder if it wasn't painful. I have had patients come to me say, the pain's gone, it's just stiff. I wouldn't do an injection just for a stiff shoulder, but that might be where it's more just stiff that you would consider doing it without steroid. But for me, injections are about pain relief.
Okay, and any studies comparing hydrodilation versus MUA for frozen shoulder?
There is. I'm not going to be able to quote anything because I'm mainly focused on steroid versus hydrodilatation. So I can't really answer that question. I don't know if Lorenzo or Mike have got...
No, not particularly. I can't remember. I was any one that springs to mind that's compared the two off the top of my head with regards to frozen shoulder contracture syndrome. No.
Okay.
Certainly the number of
the Americans,
sorry, Lorenzo.
some of the Americans do a combination of adhesive, a hydrodilatation, a nerve block, and a subacromial injection together.
Yeah. So that's definitely a valid point. And there's a question there about, could you do a suprascapular nerve block as well? And absolutely, you could do it. And there's also a study that says that if you add a subacromial steroid bursa plus intra-articular, that they do better than intra-articular. And that is a technique that I've used a certain amount.
I quite often, if you do a quick pre-scan before you do your distension, if the patient has a slight enlargement to the subacromial bursa, I will often do a small subacromial bursa injection as well. Because what I've found is that after a period of time, they come back with a little bit of a bursal type pain, bit of a type of an impingement, because the movement's improved because you've reduced the pain, but they've got some capsular restriction, not a lot. They'll often come back and you end up doing a little injection into the bursa to reduce the pain. So with some patients, if they've got an enlarged bursa at the time of the distension, I'll also give them just 20 milligrams of Kenalog and a couple of mils of local after I've done the distension.
Cool.
Okay, a lot of questions coming through.
Why don't we move on, right? Let's move on.
Yeah. Mike, do you want to share your screen and we'll go?
Okay, thanks for the invite today, guys. So my topic for this afternoon is suprascapular nerve injection, and then follow that up with a barbotage of a calcification based around the shoulder. So a quick recap for the anatomy of the suprascapular nerve. As it comes through the top of the scapula there on the right picture, you can see it comes under that notch. The important thing to remember is that there's two branches that come off at that point, one of which supplies the superior articular area of the joint, and then the second one, as you can see, supplies the supraspinatus muscle. Just so that sometimes people have talked to me about doing a suprascapular nerve block and they've injected it at the springoglenoid notch, which is the one below. Now, if you do that, obviously you're potentially not going to get that superior branch that comes off before the springoglenoid notch. So it's just to be aware of that. And I would always go for the springoglenoid supraspinatus notch at the top. There's also quite a lot of variation in the suprascapular notch. There's 6 versions there, as you can see. And also, you can get variation with what's inside the notch and what's outside the notch. So sometimes you can get, as you can see on the top picture of the right, there's all 3 structures in there. And then you can sometimes get the vessel on the outside, the nerve on the inside, and various permutations like that. So it's just to be aware of that. There is variation in normal anatomy. So my favoured technique for this injection is always in a long sitting position like that, just because it gets the patient comfortable, and also you can place the machine so that you're looking in the right direction and you're not turning, as Chris mentioned before, with regards to his subacromial bursa injections. I use a long needle, somewhere between 80 to 90 mil. A black spinal needle is often useful, or I've got some long blue ones that are 90 mil, and also some long green ones. The trajectory of your injection is always, the way I do it is medial to lateral. The amount of volume does vary, certainly in the literature. anywhere between 5 and 10 mil volume. It also varies on what you inject, what anaesthetic. Some use lidocaine, some use bupivacaine, and again, some use 40 milligrams of Kenalog and some use less. Okay. So there's two options for you to find the suprascapular notch. The first one is, it's quite simple, and you can place the probe across the AC joint and then just move the probe, slide the probe posteriorly, and then come slightly medially. But my favoured one is this one from the rear. There's just a little video there. So you divide the suprascapular spine into two, superior and lateral, and then just to remember, you may need to toggle a little tilt, or because it's actually a curved surface in the fossa where the nerve lies, potentially underneath or over the top of the ligament. And remember that you need to be in the scapular plane, and also remember that you may need to put some beam steer on there, again thinking about the angle of your needle entry, so you can visualize what's happening with the needle. Okay, just do that one again. So up, a little bit lateral, yeah, a little bit of a tilt, yeah, until you find it. And it looks like this on the right, as you can see down at the bottom. You're getting high signal from the bottom of the scapular fossa, and this small, very shallow, this one, yeah, as you can see. I've also put Doppler on there just to try and identify that artery. And as you can see, it's a very small signal there, but you can just see it. Okay, so this is where you have to use a little bit of calculation to think about your needle length. So as you can see there, the notch is underneath the supraspinatus and also underneath the trapezius. So depending on the size of your patient, if you've got a big rugby player, you're going to need a long needle, yeah? If you've got a thin little old lady or something like that, obviously that muscle bulk's going to be a lot less. So we've got a 3.5 centimetre depth there. And then if we think about the width of the probe, the yellow triangle at the top is the centre of the probe. My probe's 5 centimetres in length. Width. So if you were to take that from the edge of the probe, you'd see there, you're going to need at least a 6 centimetre needle to get anywhere near that. So it's worth just remembering that. And again, as you can see, the angle of that needle going in there is not going to give you great visualization. So that's where you need a machine that has beam steer on, makes it much better. Okay. What I then do is, once I enter into the trajectory, enter down, I tend to just inject a little bit just above the ligament. Just because what that will do, it'll just create you a little acoustic window, and sometimes can improve your visualization of that area. Because what you don't want to do, yeah, is stick the needle straight into the vessel, yeah. And you can just improve that a little bit for you, and then you can advance it a little bit further, and then deposit and inject what you your cocktail of what you've decided to do. One thing I always do as well, which I forgot to mention, is I always mark up where I'm going to put my needle, just because I like to do a pre-scan first, and I can put a little mark on where I'm going to enter in with the needle, and then I'll sterilize the probe and the skin after that. So here's the technique. Yeah, this is a left shoulder. So coming from the medial side, aiming towards the lateral. And as you can see on the right hand side, you can see the trajectory of the needle coming down towards the notch. And you can see it's not overly clear, yeah, but it's clear enough, and you get enough visualization to see where you are. Okay. So the top tips really for doing that injection is prepare well. Yeah, I always do a pre-scan first, and I always mark up where I'm going to insert the needle. Don't rush it. Yeah. always advance the needle and check the trajectory, because if it's not quite right, you can always bring it back and readjust. And again, just a little injectate just above the notch is often useful, and it can just improve your visualization. And then advance and complete your injection. It's quite a simple procedure, as long as you're methodical in what you do, yeah, like I am with my technique, and it is quite an easy one to do. I tend to use that injection with generally sort of inoperable OA shoulder, elderly patients who don't want or are not fit for a shoulder joint replacement. And I have done quite a few post-stroke shoulder pain, which has also been useful to reduce their pain. I don't use that injection for a frozen shoulder contracture syndrome. I tend to go for an intra-articular or a hydrodilatation for that. Okay. Shall we move on to the next one, or do you want to questions now?
Next one.
Go straight to Lorenzo if he wants to. If you stop sharing the screen.
No, next one. Let's go.
I've got one more.
Mark's got one more.
Okay, so next one is a barbotage procedure. Why is that not working? Okay, just a quickie there. So calcific tendinopathy, it's quite popular, most common between the age of 30 and 60. It affects females slightly more than males. It can be asymptomatic in up to 20% of individuals who've got it, and it can be symptomatic in up to 60%. So there's a bit of variation there. I know people who've definitely got calcific tendinopathy and have no pain, but ultrasound does provide an excellent means of identifying it. And obviously the common sites are around the shoulder, where we probably do most of my work with regards to this. So with ultrasound, obviously it's really good to visualize the calcification, certainly if they're coming to you with a shoulder problem and presenting like they generally present. If it's extremely painful, they can't move the shoulder, but if they've had it for a while, sometimes they present like an impingement. You do get variation in size, and from my perspective, if it's only a couple of millimeters in size, then it's not worth bothering with, because that's not probably the pain driver that they've got. You get two types of calcification. The one on the left is a picture of more of a hard and a firm deposit. As you can see, there's a little bit of acoustic shadowing underneath it, and you can see it's almost cystic in nature. It's almost got a cortex around it. As if you look at the one on the right, it's not quite as defined. It's almost amorphous, cloudy-like. Yeah, and these tend to be a softer calcification. There is some theory that at this point it's in its reabsorption phase, and also that they talk about it can be more painful in its reabsorption phase. I'm not personally convinced about that, but there is some literature out there that supports that. So again, obviously pre-procedure, sometimes people have an X-ray, but I would always want to know the size of this calcification. And again, with an X-ray, you can't really say where it is. You're much more accurate when you do an ultrasound, and you can really identify, is it in infraspinatus or supraspinatus? Also, I also want to know, is there a tear there as well? So that's important from my perspective. So again, there's two techniques that's in the literature. My favorite technique is a single needle technique, because the two needle technique is very tricky and you need a second person really. So I'm talking today about my favorite technique, which is a single technique. And this would be an average setup that I'd have. I'd have a 10 mil syringe with local anesthetic in it. I don't always fill all the 10 mils up, but as you can see, that one there's got about 8 mils in. I use a cream 19 gauge needle. Then I would fill 3 or 4 5 ml syringes with about 3 to 4 mils of sodium chloride, and then I can't see the other one on the side, is just a little bit of cortisone and maybe a little bit of local in that small 2.5 syringe, and that's for injecting the bursa after. Okay. So again, I tend to do it in this long sitting position, but a little bit more tilted back than that. Not quite flat, but not quite as high as that picture shows you just there. So I always do all my injections in sitting, and I approach it from the lateral approach. Just get the patient just to relax their arm down. If you need to, you could always ask them to hitch the bum up and put the palm underneath there, just to get it nice and stable, because you don't want them to move. I will also then do a scan, visualize where that calcification is, both in long view and short axis, and then I would mark up. What I tend to mark up with is a needle sheath, a plastic needle sheath that I've just dropped in to a little galley pot that's got some chlorhexidine in it. So it sits in there until I need it. And then I would just mark where I'm going to go with my needle, with the needle sheath, just onto the skin. It leaves a little dimple imprint there, and it'll stay there for a few minutes. I can then do what I need to do to the probe if I need to do anything, sterilize the patient, chatting away to the patient all the time. What I then like to do is try, it's not always possible, to do a slight upward trajectory of the needle. Yeah, I don't know why I do that, if I'm perfectly honest, but I kind of think, well, gravity might be of use when I'm trying to get this out. I would then insert the cream needle into the subacromial bursa, and I would inject a couple of mils of local anaesthetic in there, as you can see here. Talk to the patient all the time, how are you doing, etc. As before, flowing away from your needle. And then I would just wait for a couple of minutes and just chat to the patient, just to make sure that that's anaesthetized. What I'd then do is what I call walk back the needle. So I withdraw the needle, but don't take it out of the patient. So you're just going to walk that needle back, probably, as you can see there, to about somewhere here. Re-angle your needle to aim towards the calcification. Just before you get to touch the calcification, I'd always, again, just inject a little bit of lidocaine or bupivacaine, whatever you're using, just on the edge of the calcification, because sometimes it can be exquisitely tender, sometimes it's not. And I've done that from experience, and this is where I'm not always convinced about the painful stages, because I've touched it before with the needle tip and patient said there's no pain at all, and I've got just close to it, I've not even touched it, and patients have been in quite a lot of pain. So I tend to just, as routine, pop a bit in, have a little chat again, and then I'll advance the needle into the calcific deposit. Now, depending when you enter...
Mike, 2 minutes, okay, Mike?
What?
2 minutes, just so we got time
Okay.
for Lorenzo.
Oh, so as you enter into there, you'll realise if it's hard or if it's soft, okay? So the barbotage element is that where you're actually passing the needle. I put one into the lump and the calcific deposit, and then multiple movements inside that cystic presentation, okay? Then what happens, yeah, often the needle can get blocked, okay? So you've then got two options to clear that needle. Well, three, I suppose. You can take it out, put another one on and put it back in. I don't favour that. What you can do is you can take the syringe off, get a green needle which will slim down inside the cream, and you can push out the calcification that may be in the end of the needle to unblock it. Or my favourite approach is I'll put the probe down and I hold the syringe with my left hand, and then I'll put the edge of the syringe in my palm and then hold it, and then use pressure to push it out. But you've got to hold the syringe tight with the left hand so that you don't suddenly jerk it and go through, okay? what happens when you clear it out and then you start to plunge, you'll see that. As you can see, that calcification is enlarging and then going down. And that's the nature of the pumping action. Yeah. So what happens at that point is that the injectate is still the local anesthetic at that point, is mixing with the calcification inside. And so it liquefies it a little bit and it helps it to, when you start to try and lavage it out, okay? And this is what it looks like. So, and then the pumping action, you can see now it's starting to come out. So the pressure in, release off the syringe, and the pressure pushes it back out. And I would do that until all of that becomes very milky, yeah, and then I would change the syringe with one of the smaller sodium chloride ones and carry on. Once I've got out as much as what I think I need to get out, and once you've got the probe on there, you'll see it reducing in size. I would then withdraw the needle, and then I would just do the small subacromial bursa injection with the green needle. I'll try and go through the same puncture wound and just pop that into the subacromial bursa, and then withdraw the needle. Finished. And then what you should see, yeah, that's straight after on an ultrasound, it's completely gone. X-ray, it's completely gone. And this is what you can see inside your syringes, yeah. And if you hold them still, after a few minutes, it all settles down to the bottom. Here's a little bit of evidence for the use of barbotage. It is a useful technique with a very high success rate, low complications, and it's certainly worth doing, I think, rather than having surgery, in my opinion, to start with anyway. Thank you.
Before we'll go straight on to Lorenzo, and we'll save the questions to the end unless there's anything very specific to that. But yeah, Lorenzo, do you want to share your screen? Yeah.
Mike, can you stop?
Yeah, there you go.
Okay. Yeah.
Have you got my screen there?
Yeah.
Okay, fine. So I am going to talk about ultrasound guided injections. To start that. Sorry, I'm not getting this. Why isn't it working?
Use the white one at the top.
Let me go with that again. Sorry, apologies for this. Okay, fine. Great. So I'm a sports and exercise medicine consultant. I work privately in a number of clinics in central London. I have an interest in ultrasound and also an interest in tendinopathy.
Can you see it, guys?
Yeah, he's not sharing your screen.
It's not sharing or anything.
Oh, it's not sharing. Okay, sorry, apologies. So
Green one at the bottom.
got it there?
Yeah.
That's it.
Okay, fine.
Yeah.
Right. So I've got an interest in ultrasound and ultrasound guided injections as well as tendinopathy. I'm going to talk today about ultrasound guided injections in tendinopathy. Two take-home principles. First principle is ultrasound guided injections, or any injection must be used in conjunction with a rehab program. There's no point in doing an ultrasound guided injection because it only forms a tiny component of the rehab program. And the second principle is think about what you're doing and try and clinically reason. So all of these videos are taken from Sonoskills. They've done an online ultrasound guided injection course, which I help to direct and produce, and that can be accessed through 123 Sonography. And I've referenced as many pictures as I can in cases where it's not my material. So tendinopathy, in my opinion, despite 30 years of research, is really an enigma. It's a complex pathophysiological process. Some people think it's tenocyte mediated. Other, certainly more recently, there's evidence of chronic inflammatory cells, not the typical acute anti-inflammatory cascade or inflammatory cascade, but certainly there are chronic inflammatory cells that may that may combine with the tenocyte to produce the pathology. So, not sure about the pathological process, which is important because you need to clinically reason with regard to injection therapy for tendinopathy. More importantly, we actually don't know where the source of pain is coming from. There's a number of studies that show that there's evidence of local nociception, but certainly there's also evidence of central processing changes in the brain and spinal cord. So it's a very complex process that we know very little about, in my opinion.
Lorenzo,
Sorry to interrupt, your slides that it's not coming up properly. We've just got the title of tendinopathy is an enigma.
Oh, okay. It's not coming up.
No. Just unshare and share again. See if that.
Wow.
Yeah, just try it again.
We can see it now. Just go from there.
Fine.
Just move them on from there.
Yeah, that's.
Yes, click that. It should be all right.
Oh, it's not working for some reason.
Mike, I think you click on the custom slideshow, which should be fine. When you click slideshow there, and then you can see the third one. 1, 2, 3, 4. Sorry, not the third. Fourth one.
No.
From begin. No. From beginning.
Custom slideshow, probably.
Sorry, am you talking to me or you're? So I'll stop sharing.
Yeah.
And then I'm going to PowerPoint. Yeah.
That's it.
Yeah. So
Don't go from.
So it's not for some reason it's not allowing me to.
Can you click the bottom right where it's just got the little arrow?
Yeah.
Right, awesome.
That one.
Yeah.
Okay. Yeah. You see it?
Yeah. Just maybe you could go from that slide because it's not, for whatever reason, it's not working. But that we can.
Is it working now?
We can see like the whole kind of selection.
Right.
Sorry, Lorenzo, can you try to click on slideshow again, and then you count 1, 2, 3, 4. The fourth one is gonna be like a customized slideshow. Try to click on that one, please.
Yeah. Try that, Lorenzo.
So we go.
Slideshow.
Custom.
So down here.
No.
Top.
No. Top. Yeah, so I've done that. Slideshow.
Yeah. And then
custom that
number 4. That's it.
And I've got.
Try it again. Double click it. See if it works.
So slideshow. No.
All right. Okay. Another option. Sorry, Lorenzo. Can you hear me?
Yes.
Another one, can you double click on your slide now? This is your slide, main slide, right? Can you double click on it? And you can see the bottom on it's like a toolbar on the bottom there, and you can see the figure like you can see on the how can I say it? It's like a there, and then you click on it, and you can show a slide.
You're not seeing that, what I've got there? No?
No.
No.
That's better.
Yeah, yeah.
That's better.
You see
Only
that?
half a slide. Got half a slide there.
That's the slide. You see that?
Press forward. See if it goes to the next one.
So I'm going to the next one.
No, you can't see it.
Okay. Sorry about this, but I don't know why it's not working.
Right, Lorenzo, let me share my screen because I've got yours anyway. So let me just try this way. And just. Okay.
There we go.
There you go.
How do I move it though?
There you go.
Tell Andy.
I'll put it in my hand.
That's it. Finger up like that.
Okay, so we'll move on to the next one. Next slide. So we know that exercise therapy is the most effective treatment, and this is a seminal paper by Beer et al. But how effective is exercise? If you look at the evidence, about a 30% non-responder rate. What are our options for those that don't respond? We've got shockwave therapy that has low-level evidence. We've got GTN patches that has mixed evidence. And then when you look at surgery, if you compare surgery to sham surgery, physiotherapy, it's no more different than, or there's no evidence of increased effectiveness compared to sham surgery or physiotherapy. We'll go to the next slide. Okay, so what do we use as clinicians? We use this, which is cortisone injections. And there's over 300,000 cortisone injections performed in the UK per year. How effective is cortisone? So this is a narrative review that I produced with John Orchard, who was the first author. And if you look at the evidence for cortisone in tendinopathy, while there's growing evidence of short-term effect, there's really a question mark about long-term effect and particularly about harms, certainly with certain tendons such as tennis elbow. So we need to be cautious about using cortisone in tennis elbow and other tendons. How does cortisone work? We're not sure. It could be tenocyte downregulation, it could be anti-inflammatory, it could be other mechanisms. We have a number of cortisones that we can use. We can use Canalog or depomedrone, which are colloid type cortisones, and then dexamethasone or hydrocortisone, which are non-colloid. What injections do I use cortisone with? What tendons do I use cortisone with? Subacromial bursa is one, trigger finger, and another one here, de Quervain sinusitis. These tend to be more inflammatory type pathologies, so they tend to be more effective with cortisone injections. Next slide. So this is an example of a de Quervain sinusitis injection. So the patient is usually sitting next. The patient's sitting. The practitioner is facing the ultrasound screen. You use a 25 gauge needle. You do an in-plane axial approach. Next button. Press. So here you can see the first dorsal extensor compartment. Use a 25 gauge needle. Press again. So this is the approach that you would use. This is on a cadaver. Press the button. You can see the needle coming from the right side. So it's an in-plane axial approach. You can use local anesthetic and cortisone. And the key is to get the needle into the tendon sheath. So that's the key. And that's the advantage of using ultrasound, is that you have this increased accuracy. As a result of the increased accuracy, we can see from studies that there is some evidence of increased effectiveness, certainly evidence that of reduced side effects. The dose that I would tend to use is 10 to 20 milligrams of depomedrone and local anesthetic or normal saline. Okay, next slide. But there are other tendon injections you can do. There are extra tendon injections that you can do. So what are these? Well, I mentioned that there are certain histopathological and immunochemical studies that show that with tendinopathy, you see an increase in blood flow, and with that blood flow is this neural infiltration or peritendinous neural infiltration. And that peritendinous neural infiltration is sensory and sympathetic, and potentially could transmit pain perception. Next button. So we know the blood flow is a marker for neural infiltration. Next button. So I work with this Professor Håkan Alfredson, that uses this general principle. So this neural infiltration, uses this principle in his surgery. So this surgery is minimally invasive surgery. Press the button. So again. So you see here, this is a tendon debridement procedure. So in essence, what you're doing is you're partially denervating the tendon. Now, some practitioners have taken this procedure or this clinical reasoning and have devised injection therapy. Next slide. So this is called a high volume injection. So the patient is usually in the prone position. The probe is placed axially to the tendon. So this is the tendon here, and you often have this blood flow. So this is your target, and the target here is the interface between the tendon and the fat pad. So the needle is placed in an in-plane axial position. The target is this infiltrate. Next button. So use local anesthetic, normal saline, plus or minus cortisone. Press the button. So the needle arises from the right side. So the target is that interface between the Achilles tendon and the fat pad. And this is where the nerves are. So in essence, what you're doing with a high volume injection is you're trying to partially denervate the tendon. You can see here right. That's fine. So that's fine. Move on to the next slide. What is the evidence for high volume injection? Well, actually, there's limited high-level evidence in Achilles tendinopathy. These guys here, these are Danish surgeons, and they've done 2 studies looking at high-volume injections and Achilles tendinopathy. They use the same protocol as the group in central London. They use bupivacaine 10 mils, 20 milligrams of dipamidrone, and 40 mils of normal saline. Press the button. So they looked at two studies. First study was high volume with cortisone versus PRP versus placebo. And what they found was the high volume with cortisone had a short-term positive effect, but at 6 months, there was no difference between high volume with cortisone and PRP. They did another study looking at high volume injection with cortisone versus a high volume injection without cortisone to find out whether that positive effect was a result of cortisone or the result of mechanical denervation. And what they found was a similar effect. So you've got this positive short-term effect with high volume with cortisone, and this was the effect of high volume without cortisone. What this indicates is that, in fact, high volume injection with cortisone, the positive effect is perhaps a cortisone effect. So when you're doing a high volume injection with cortisone, it's just a cortisone injection. And that's fine as long as you say that. Now, some practitioners, me included, have tried to increase the mechanical denervation. Next slide. So they're using this bespoke instrument. So this is an instrument here. This is a needle. This is taken from Medrick Hall, who's a sports physician in Iowa City. This is a needle with a short blade using local anesthetic only and no sutures. Press the button just once. So here you see a denervation procedure of the Achilles tendon. So you're doing what you do in surgery. You're trying to target that interface between the tendon and the fat pad. And then below that, press the button, is the same picture that you would do within a patellar tendon. So you're targeting both the superficial and the deep surfaces of the patellar tendon, because you often see blood flow in chronic patellar tendinopathy. You see blood flow on both surfaces. So there's another option here. So people are moving away from high volume more into percutaneous scraping procedures. Next button. So I talked about the extratendinous injections, cortisone injection. I talked about high volume injection and percutaneous scrape, but there are intratendinous options. So this is an example of a tennis elbow dry needling procedure. So what you do is you put approximately 20 passes into the tendon. The mechanism of action is unknown. It might be a remodeling, it might be anti-inflammatory effect. But if you look at the evidence, there's certainly lower level evidence for percutaneous tenotomy. So I tend to use this percutaneous tenotomy in tennis elbow, hamstring origin tendinopathy, and in some cases of calcification, as Mike was saying with his barbotage. So this is an example of a hamstring origin tenotomy. So this is the ischial tuberosity, this is lateral, you've got medial, and so you're going from lateral to medial, and you're in essence needling the tendon. Next slide. So this is an example of something you would do with a tennis elbow injection. So the patient is sitting or lying, the elbow is slightly flexed, transducer is longitudinal position, you use a 23 gauge needle. This is the lateral epicondyle. Moving down here, you've got the radiocapitellar joint, and you've also got the radiocollateral ligament. So this is your target here, which is the extensor tendon. Press the button. So this is an example of a tenotomy. So the needle's coming from the right side, so you're going right to left. You're moving the needle in plane longitudinal, and then injecting initially with local anaesthetic and then dry needling the tendon. Next slide. But I'll be remiss without actually mentioning something about platelet-rich plasma. There have been a few studies on platelet-rich plasma. Certainly it's a growing field, and it's a discussion within itself. Press the button. So we've gone through the evidence for platelet-rich plasma and tendons in our narrative review, but there's also a systematic review and meta-analysis by Professor Jane Fitzpatrick. And what they showed was there were positive short-term effects for platelet-rich plasma in tennis elbow, plantar fasciopathy, and glute med tendinopathy. But, and this is the big caveat, is that many of these studies have been compared to cortisone. So if you compare platelet-rich plasma to cortisone, in fact, what you'll see is that you'll see platelet-rich plasma looks a lot better because cortisone has potentially a negative effect in many tendons. Just a quick shout to these guys here. This is the group in Barcelona, fantastic group of sports physicians and radiologists. They're actually doing a randomized controlled trial comparing stem cell injections to low leukocyte PRP, and the results are just out of that study. Next slide. So this is what you would do in for example, an Achilles tendon PRP injections. You would use 3 to 5 mils. You'd use a 21 gauge 2-inch needle. The transducer would be in plane to the Achilles, and you would do an in plane longitudinal approach. Just press the button. So this is the approach here that you would use. So the needle goes in plane longitudinal. You'd start from the distal end and you would move proximally, and then you would target areas of pathology. So it's an intratendinous injection, which is different to many of the injections we discussed previously, the high volume injection, which is below the tendon, between the tendon and the and Kay's fat pad. Next slide. So this is an example of a similar sort of injection. This was done by the group at Stanmore, headed by Andy Goldberg, and fantastic group of radiologists, Ruth Green and Paul O'Donnell. I was involved in this study. This is a stem cell study. So this is the same procedure that was done here. So it's in plane longitudinal approach. In essence, what you're doing is you're injecting the stem cells 1 centimeter proximal and 1 centimeter distal to the thickest part of the tendon. And that's how they did a stem cell injection into the Achilles tendon. Next slide. So in summary, injections are a tiny, tiny component of tendon management. That's important. Injections are always, always an adjunct to rehabilitation. I think you need to use clinical reasoning when you're thinking about what type of injection you're doing. We know cortisone has a diminishing role. You need to be cautious about cortisone. There is some evidence that potentially could do harm, particularly for tennis elbow. There are other injections you can do, high volume injection with cortisone or percutaneous tendon scraping. And then there are intratendinous injections, the needling with local anesthetic or PRP. Very, very important that you need to avoid harming your tendons. Anytime you're introducing an intervention like an injection, there's always the potential to introduce unpredictability and potential harm. And in tendons, that could mean rupture. So you need to be really cautious about doing these injections. If anyone has questions, very happy to answer. You can email me directly or on Twitter or LinkedIn. That's it.
Thank you very much, Lorenzo. That was really good. Okay, yeah, there was a lot of questions coming through there. So let me just scroll up here. So in terms of we've got a question here from Powell. How is sham surgery classed?
So sham surgery in those studies are, we're looking at, so for example, tennis elbow, what they did was one half of the patients had the tennis elbow surgery and the others had the local anesthetic or the general anesthetic. They went in and they pretended to do the operation. They did a little incision into the skin, but they didn't actually touch the tendon itself. The other study was looking at shoulder arthroscopic surgery or decompression surgery. They had one group having the procedure and the other group having a quick look in with an arthroscopy or a pull out. So it's pretending to do the operation, but not telling the patient that you not had the operation.
Okay, great. Then another question here. Several systematic reviews recently published conclude that CSI has only short-term effects, 2 to 4 months in tendinopathy.
That's
What's your experience in this?
Yeah. So, I mean, in the narrative review, it's quite clear that cortisone injections only have a short-term effect. There are real question marks in the medium to long term. And certainly in some tendons, such as tennis elbow, there's evidence of medium-term harm.
And are there any...
I think the therapeutic window for cortisone in tendons is rapidly diminishing. So the ones that I tend to do are subacromial bursa and the inflammatory type conditions. So trigger finger, de Quervain, and sinusonovitis. I tend to stay away from cortisone injections for the large weight-bearing tendons, so Achilles tendon being an example, or patellar tendon.
Okay, great. And do you ever use scraping in combination with HVI?
So what you do when you do a scraping procedure is that you often do a little high volume injection to start with. So what I tend to do is I put local anesthetic in that interface between the tendon and Kager's fat pad, and then I put the actual needle in. So I do a little high volume injection with local anesthetic, and then put that bespoke needle instrument that I showed that has a little blade, and then do the scraping.
Okay, and a question here as well in terms of what kind of needle you use for that scraping. Is it a specific name thing that you'd use for that?
So there's a little bespoke instrument. It's called Admix, ADMIX. You can buy it. They come in different sizes. I tend to use the 16 gauge and 18 gauge needles. And they're such that you don't need to actually use sutures as a result of placing the blade through the skin. So they're tiny little holes that you make. So there's no need to actually use sutures. And that's the key to doing percutaneous scraping, is that you don't have to necessarily use sutures and increase the risk of wound breakdown and all the complications.
Okay, that's interesting. I'll bring in Chris and Mike on this one that's talking about the HVI, but in addition to eccentric exercise, that's more effective for Achilles tendinopathy. What are your thoughts on that combination, Chris? I
mean, I wouldn't do I wouldn't do a high volume without a loading program. The justification of any injection is really to control pain in the short term, to then engage in a loading program. If you're just injecting and there is no follow-up physio or loading program, then in theory that's pretty much a contraindication to a weight-bearing tendon, lower limb tendon. So it's got to be a combination treatment, and that's where a lot of the studies haven't done that when it looks at cortisone, or some haven't.
Okay. Great, thank you. So a question from Chris. Does anyone use local anaesthetic with PRP, perhaps even as a proximal nerve block?
So in my opinion, if you're going to be using PRP, you shouldn't be combining it with local anaesthetic. If you want to use local anaesthetic, you can use it in the skin and subcutaneous tissue. There's no point in actually injecting local anaesthetic into, say, for example, a tendon if you're going to be putting PRP in there, because local anaesthetic will negate the effect of the PRP. So
I think he's talking about doing a nerve block with local before doing the PRP. That's a
you could do that if you want to. It's like putting local anaesthetic into the subcutaneous tissue.
Yeah.
Okay. And do you prefer low or high platelets PRP for tendons?
So with regard to what's better, low leukocyte count, high leukocyte count, the jury is definitely out, although there is some evolving evidence that maybe high leukocyte count is better for tendons, low leukocyte count better for joints. Although if you look at the studies, it's pretty tenuous.
And is there a limit in terms of the number of injections for PRP that are allowed in any joints?
If you're talking about joints, no. But if you're talking about tendons, the answer is we don't know how many injections are favourable or optimal for a particular tendinopathy. So the answer to that is we don't know.
Okay.
In my opinion, with PRP, I think there's not enough evidence to suggest that we should be using it regularly for tendinopathy. I think there's some evidence, as I mentioned, potentially for certain tendons such as tennis elbow, plantar fasciopathy, and gluten tendinopathy. But as I mentioned, those studies that have been done have been compared to cortisone. So we know that cortisone in some cases do worse and it makes PRP look better. So we need to take that into consideration when clinically reasoning about PRP injections.
Okay.
One question there from Adam Garnett. The scraping technique, you generally target the area where you've got the highest amount of neovascularization. So where it's going from the fat pad into the tendon. So you target the neovessels. Same as high volume. In terms of Fred's question, even if you're doing an injection and they failed loading before, you can't just say they failed loading. You need to find another way of loading, but they need some sort of return to sport. So whether it's direct physio, but they still need some way of increasing the load through their tendon. So it might not be physio, but it's a progression of load, even after an injection if they failed physio before, which I'm sure is what Fred's doing anyway.
And in terms of the use of cortisone for plantar fasciitis, Lorenzo, what are your thoughts?
I think if you look at the evidence, it provides only short-term effect. You need to be cautious when doing plantar fascia injection. I certainly would not do an injection without ultrasound guidance, because you don't want to inject into the plantar fascia. But the evidence suggests it provides only short-term benefit, just like the evidence for cortisone for other tendons. So do I use it? Yes, I do. I probably use it just the once. If it doesn't work, then I'd move on to the next stage. There is, as I said, some evidence that maybe PRP injections might be useful for intractable plantar fasciopathy, but it's not my preferred first line or second line treatment.
Okay, great, thank you. Mike, does the barbotage technique is it indicated effective for both hard and soft calcification?
Yes, yes, use it on both, definitely. And there was also a question about if you don't get any out, so that would just be a barbotage procedure. And you can just do that. You can just break it up with the needle and just then withdraw the needle and leave it. Yeah. But I find that it's better if you can get some of it out. If you don't get all of it out, it doesn't matter, because you're creating a reaction within that tendon that, because as we know, often it's self-limiting and reabsorbs anyway.
Okay, great. And last one's come through here. Do you use a cover for the probe?
Me?
Well, yeah, ultrasound, I guess they're talking about that.
I don't tend to use a probe cover. I disinfect my probe between each patient. That's just my personal preference.
I don't use a probe cover. I'm not aware of any evidence that necessarily says we should. You shouldn't touch the probe anyway, but it all comes down to your local policy and your local guidelines. If you want to do absolutely everything out there to reduce any chance of anything, then using a probe cover would be part of that. But my experience is that a lot of people don't, but that doesn't mean it's right or wrong. I don't personally, but there's definitely a case to say you should if you want to tick every box.
And then another question from Fred. So Lorenzo, you've presented data of the EPTE, but you didn't mention the only positive study in plantar fasciopathy.
So I don't use EPTE myself. I am not aware of any positive studies on EPTE. You know, there may be. You know, if there are any high-level studies, I'd be willing to look at it. That's EPTE. I know what EPTE is. It's a injection. Well, it's not an injection, but you use an instrument that changes. My understanding is the local pH of the particular area that you're treating, done under ultrasound guidance, and supposedly has positive effects on pain and function. I haven't seen any high-level evidence studies suggest that it's more effective than any other injections. I'd be willing to look at it though.
Lorenzo, there's a good question on prolotherapy, and you've probably yourself and Håkan have probably done the most prolotherapy in the world on Achilles.
Well, I mean, I think.
What do you think?
So with prolotherapy, it's the same sort of principle. What you're doing is targeting the peritendinous neural infiltration in that interface. So you're targeting the blood flow, and where the blood flow is where the neural infiltration is. Certainly had mixed results. I tend to use it more for insertional Achilles rather than mid-portion Achilles tendinopathy.
But you're targeting the neovascularization. You're trying to zap that.
Yeah, you're not going into the tendon.
Great, we've gone quite a bit over there. What I'll say is we'll send out a follow-up email on this, and if there are any specific questions, we'll put the guys' contact details in, and please feel free to fire them through. We will be doing more webinars, so please put that in any particular request that you've got for those ones. But finally, big thank you to Lorenzo. Thank you very much. Mike, thank you. And Chris, big thank you for joining us this evening.
Thanks for organising, Andy. And if anybody wants to look at the courses, it's ultrasoundtraining.co.uk. You'll see the cadaveric courses there and some other courses. So it'd be great to see you guys on one of those courses. Thank you.
Yeah, we'll send out a follow-up email over the weekend. So any questions, please let us know, and we look forward to seeing you next time.
Thank you. Sorry about the IT issues.
No problem.
Bye.
Cheers, guys. Thank you.
Thank you.
Cheers, guys.